Hello everyone, I'm Dr. Rohan Khandelwal, your Marrow Surgery Faculty, and in this video I'll be discussing the second part of INICET Surgery PYQs and 28th edition Bailey updates. In this module I'll talk about endocrine surgery and trauma surgery, both of which have significant updates in the latest edition of Bailey. And these are potential questions for the INICET exam. So the first question from breast surgery is regarding the molecular classification of breast cancer, which has been asked multiple times in the exam. So this is a 39-year-old female who comes with a lump in the left breast, and she has been diagnosed with basal-like breast cancer. Now they are asking basal-like breast cancer is what type of molecular subtype? So we know basal is triple negative breast cancer. It is triple negative breast cancer. So all three would be negative, that is ER, PR, HER2/neu, and that is the correct answer here. This is the molecular classification of breast cancer, which is based on gene expression profiling, and all of you should remember this. Luminal A is the most common and it has the best prognosis. This is ER, PR positive and HER2/neu negative. The Ki67, which is the proliferation index marker, is low in these patients, as is cytokeratin, which is negative. Now, luminal B can be like luminal A, that means ER/PR positive, HER2/neu negative, but the Ki67 is high, indicating that the tumor is multiplying quickly. Or it can be triple positive. HER2/neu enriched is ER/PR negative, HER2/neu positive. Basal-like, which is the classical triple negative, has the worst prognosis. This has also been asked, but you should know about the TNBC paradox. The TNBC paradox is that these tumors are very aggressive, but they respond very well to chemotherapy. Right, so that is the paradox, and they of course have a high chance of recurrence as well. In basal-like tumors, cytokeratin 5 and 6 is positive. The last one is Claudin low, which has been updated in Bailey as well. This is also triple negative, but the cytokeratin markers here are also negative. Now, a major update in Bailey is where they've expanded the indications for neoadjuvant chemotherapy. Now, we know neoadjuvant chemotherapy is chemotherapy given prior to surgery. So, any treatment which we give prior to surgery is known as neoadjuvant. So the indications for neoadjuvant chemotherapy in breast cancer are locally advanced breast cancer, then triple negative breast cancers. This is very important because I told you triple negative breast cancers or basal type of cancers respond very well to chemotherapy. It is now given prior to, in these patients we tend to give neoadjuvant chemotherapy. Similarly, HER2/neu positive tumors also we give neoadjuvant chemotherapy. If the patient is desirous of BCS, breast conservation surgery, and the tumor is big, then also we give neoadjuvant chemotherapy in patients. So these are the indications for neoadjuvant chemotherapy. The advantages of neoadjuvant chemotherapy are it serves as an in vivo chemosensitivity indicator, right? It serves as an in vivo chemosensitivity indicator. What does this mean? This means that when the tumor is inside the body, I will objectively know whether the tumor is responding to chemotherapy or it is resistant to chemotherapy. Right, so we get an indicator there. Second, it takes care of micrometastasis. It takes care of. And third, it downsizes the tumor and it can make it eligible for breast conservation surgery. Now, there is another term known as PCR. PCR is pathological complete response. Pathological complete response means the tumor completely goes away. So that means patient had a 3 centimeter tumor or 4 centimeter tumor. We gave neoadjuvant chemotherapy, then we did surgery, but on pathology no tumor was found. That is pathological complete response, and if a patient achieves path CR, then there is survival advantage. That improves the survival, which is another advantage of giving neoadjuvant chemotherapy. Now, PCR rates are maximum in triple negative breast cancers because I told you these are the ones which respond best to chemotherapy. Now, once the patient is undergoing chemotherapy, how do we judge the response, whether the tumor has responded or not responded? So this is another update, that is the RACIST criteria. The RACIST criteria stands for Response Evaluation Criteria. This is response evaluation criteria in solid tumors. Response evaluation criteria in solid tumors. So complete response is disappearance of all lesions and pathological lymph nodes. Partial response is more than 30-degree decrease in the diameter, no new lesions, no progression. Stable disease, SD is stable disease, I'll come to stable disease, and PD is progressive disease. So progressive disease is more than 20% increase in the diameter or new lesions or progression of non-target lesions. This is progressive disease. Stable disease is which is neither partial response nor progressive disease, that is classified as stable disease. So this RACIST criteria is a new addition to the latest edition of Bailey. It basically judges the response of the solid tumor to neoadjuvant therapy. Now, surgical options after locally advanced breast cancer. So LABC, locally advanced breast cancer, you know the definitions. T3N1M0 means more than 5 centimeter tumor, positive nodes, 0 or no metastasis, or any T4, any N2, any N3 with M0. All these are locally advanced breast cancers. And I've told you locally advanced breast cancers are going to get neoadjuvant chemotherapy. So when you give neoadjuvant chemotherapy, up till a few years back, it was a norm that these patients used to land up with a modified radical mastectomy. Now, if there is good response, we can even do breast conservation surgery and targeted axillary dissection. Targeted axillary dissection is when we do a sentinel node, and if we have clipped a node or biopsied a node beforehand, we remove those nodes to see if they have disease or not. Okay, so this is another update. You should definitely know about LABC. This has also been asked multiple times in the exam. So these were some updates. Moving on to the next question. You have a 42-year-old lady with a lump in the breast with no nipple retraction. Mammogram is shown below. What is the BI-RADS score? You can see on a mammogram, this is a classical popcorn calcification. We get popcorn calcification in fibroadenomas. And we know fibroadenomas are benign. So BI-RADS 2 is benign. Right? This is popcorn calcification in a fibroadenoma. This is a spiculated mass, which is a mass of cancer. Now, BI-RADS scoring is very important. You know, BI-RADS stands for Breast Imaging, Reporting and Data Systems. So BI-RADS, all of you should know, BI-RADS 0 calls for additional imaging because it is an incomplete investigation. 1 is negative, call the patient after 1 year. 2 is benign, like in the case I showed you, you call the patient after 1 year. 3 has been asked many times, it is probably benign, a short-term follow-up after 6 months. 4 is suspicious and we need to do a biopsy. 4 is further subdivided into 4A, 4B, 4C. 4A is 2 to 10% risk, 4B is 10 to 50%, and 4C is 50 to 95% risk. BI-RADS 5 is malignant, highly suggestive of malignancy, you need to do a biopsy, and BI-RADS 6 is a biopsy-proven malignancy. A 46-year-old female is diagnosed with a right breast lump which measures 4 into 3 centimeters. Mammography reveals it to be BI-RADS 4B. Patient undergoes breast conservation surgery, BCS is breast conservation, and histopathology is high-grade DCIS with necrosis. So high-grade DCIS with necrosis. DCIS we know is ductal carcinoma in situ. What is the next step in the management? We have discussed multiple times that if the patient undergoes breast conservation, then we always have to give radiation to these patients. Okay, so DCIS, ductal carcinoma in situ, surgery can be breast conservation. If we do breast conservation, radiotherapy is mandatory, or we can do simple mastectomy. Why simple? Because this is non-invasive cancer, so the lymph nodes will not be involved, so we can do simple mastectomy. There is no role of chemotherapy in DCIS, and if ERPR is positive, we give hormonal therapy as well. For DCIS, you have a Van Nuys prognostic index. This has also been asked in the INICET exam, where they've asked the components of the Van Nuys score, which includes size, whether type of DCIS means necrosis is there or not, or what is the grade, what is the resection margins, are the margins clean or not, and the age of the patient. So these 4 criterias are included in the Van Nuys score. ERPR is not included in the Van Nuys score. HER2/neu is not tested in DCIS. HER2/neu is tested in invasive cancers, not in DCIS. That is another update which I want you to know, which has been written in Bailey. Which is the investigation of choice to localize parathyroid tissue? I think so. This is a straightforward question. It is a Sestami B scan. Technetium 99 Sestami B scan is used for parathyroid localization. A patient underwent mastectomy and this drain was inserted. What kind of a drain is this? This question has been asked multiple times. We know it is a closed drain, and this is known as a Romovac suction drain, or a negative pressure drain, which we use after mastectomy, after thyroidectomy, after neck dissection. After mastectomy, this drain is removed when the output is less than 40 cc for 2 consecutive days. Okay, so drains can be open drains or closed drains. These are all examples of closed drains. Minivac is a miniature version of Romovac. And Jackson-Pratt drain has also been asked in INICET a couple of times. The difference between a Romovac and Jackson-Pratt is that the collecting device here is a bulb, and the tubing is flat as compared to a cylindrical tube in Romovac. This is a flat drainage end, and Jackson-Pratt drain can be used after abdominal surgeries as well. This can be used following abdominal surgeries. So you should know about these drains also. In a patient with breast cancer, IHC immunohistochemistry is ordered. For what value of HER2/neu would FISH need to be ordered? Now we know HER2/neu in breast cancer, IHC can be 0, 1+, 2+, and 3+. 0 and 1+ are considered as negative. 0 and 1+ are considered as negative. 3+ is considered as positive, and 2+ is equivocal. And in these equivocal patients, we carry out FISH. FISH is fluorescent in situ hybridization, and FISH tells us if HER2/neu is positive or it is negative. If it is negative, it will be non-amplified, and if it is positive, it will be amplified. Okay, so only for HER2/neu 3+ and 2+ patients who are amplified on FISH do we give HER2/neu treatment. Okay, so this also you should know for the exam. Couple of questions regarding frozen sections in INICET. All of the following are applications of frozen section except. The first thing which you should know, that frozen section, when we have to send a sample. So if I am doing a surgery and I have to send a tissue for margins, or I have to send a sentinel lymph node, I send it just like this. No saline, no formalin. So that is one question which you should know. Frozen section samples are not sent in saline or formalin. They're just sent in a container. Now, what all is the utility of frozen section? So utility of frozen section, it is used to identify the margin status. I know whether I have clear margins or not. For sentinel lymph nodes, it is used to identify metastatic lesions. So supposing I open up a case of gallbladder cancer, I am doing a diagnostic laparoscopy and I find omental deposits there. I send those omental deposits for frozen section and they turn out as positive. So frozen section can help us in localizing these metastatic lesions also. It is not used to establish definitive diagnosis. That is the correct answer here. This is sentinel lymph node biopsy. We know we can use the blue dye method, in which we use methylene blue, which is injected in the periareolar region, and skin tattooing is the most common complication. This is the technetium-99 tagged sulfur colloid which is used. This is the radionucleotide technique, technetium-99 sulfur colloid, and this is a gamma camera which helps us in localizing the hot lymph node, which is the sentinel lymph node. Another new technique for sentinel lymph node biopsy is ICG. ICG is indigo cyanine green. Indigo cyanine green can also be used as a dye for sentinel lymph node biopsy. Sentinel nodes, we know, are the first draining lymph nodes from cancer, and this has a utility in breast, vulvar cancer, endometrial cancer. But vulvar and endometrial, if both are present, you will mark vulvar as the answer. Malignant melanoma and penile cancer also. A 37-year-old nulliparous on oral contraceptive pills since the last 3 years. History of breast cancer in mother and ovarian cancer in sister. What will you advise as the next step in this patient? So we know 37-year-old nulliparous, slightly higher risk of breast cancer. OCPs, low dose OCPs which are used these days don't increase the risk of breast cancer. We know that, but there is a strong family history. Breast cancer in mother and ovarian cancer in sister. Next step advice to her would be genetic counseling and BRCA testing would be done in these patients. The new screening guidelines: women with average risk of breast cancer should start their mammographies from 40 years, and women with higher than average should be offered supplemental screening. So what is the supplemental screening? Women with average risk, I've already told you, they start at 40 years. Women with higher than average risk means hereditary susceptibility, carrier mutation status means BRCA positive, or those who've received radiation between 10 to 30 years of age to the chest wall. These ladies will start with an MRI at 25 and mammography starting at 30 years of age. The other category are strong family history, like our patient which we were discussing, or predicted lifetime risk of more than 20% by any model. Then these patients will start screening at 35 years of age. So this is something which you should know about as well. This is a very important table which I want you to remember for the exam. When is BRCA testing indicated? This is extremely important and a potential question for the exam. This has been updated in the latest edition of Bailey as well. So if there is a deleterious BRCA mutation in mother, sister, then this patient should also be tested. If there's a personal history of ovarian, fallopian tube, or primary peritoneal cancer. For patients with breast cancer, one or more relatives diagnosed less than 45. Personal history of bilateral or triple negative breast cancer, triple negative less than 60. Or if it's a male patient, then BRCA should be tested. First or second degree blood relative with ovarian cancer and breast cancer less than 45, or more than 2 first, second or third degree relatives with breast cancer, at least one of whom has been diagnosed less than 50. So in our patient whom we were discussing, the mother and the sister have breast and ovarian cancer. So she should also undergo genetic counseling and she should be offered BRCA testing. You know, BRCA1 and 2 are the genes which are responsible for hereditary breast cancer, and They increase the risk of breast, ovarian, primary peritoneal, and colorectal cancers. BRCA2 also predisposes to prostate and male breast cancer more than BRCA1. This was another very good question which was asked last year, something which we practically encounter in our patients these days. A patient of breast cancer was put on tamoxifen since the last 5 years. Now, if she wants to conceive, when should she stop tamoxifen? So, whenever we start hormonal therapy and if the patient wants to become pregnant, we tell them that you have to take hormonal therapy for 2 years at least. Before 2 years, we will not stop hormonal therapy. Okay. Now, this patient has already taken it for 5 years. So, when we stop hormonal therapy, then we say usually you should wait for 3 months before you try to conceive. Okay. So, that is the correct answer here. She should stop 3 months before and then she should start planning her pregnancy. If a patient becomes pregnant on tamoxifen, then you need to discuss with the gynecologist if they can continue the pregnancy or not, because there can be teratogenic changes. All of the following are relative contraindications for breast conservation surgery except prior radiation. Yes, because prior radiation, what is going to happen is that we have to give radiation after breast conservation, but there are newer techniques where radiation can be given again to the chest wall after a certain gap. N1 disease is not a contraindication. You can easily carry out breast conservation surgery if there is N1 disease as well. Large tumor is not a contraindication. It is a relative contraindication. I mean, not an absolute contraindication, but multiple tumors. So multiple tumors also, if it is multifocal and all the tumors are together, you can carry out breast conservation. But if it is multicentric, where the tumors are spread across the breast, then we cannot, right? So the correct answer here would be N1 disease, because in N1 disease, we can comfortably do breast conservation. There is no contraindication at all. Now, I quickly want to run through some updates which are there in the latest edition of Bailey. For core biopsy, you should know core biopsy now, Bailey recommends a 14 gauge biopsy gun instead of a 16 gauge which was given in the 27th edition. So core biopsy is the investigation of choice. This is a type of an incisional biopsy, and 14 gauge is what is recommended. Bailey also recommends that you should biopsy the axillary lymph nodes, and an 18 gauge needle should be used for biopsying the axillary lymph nodes. VAB I have already covered in my Marrow modules. This is vacuum assisted breast surgery. This is vacuum assisted breast biopsy, and we can use an 8 to 11 gauge probe. This can be used for therapeutic interventions, like we can do scarless fibroadenoma surgery, or we can even do biopsies using a VAB machine. In a patient with suspected breast cancer and enlarged lymph nodes, I just told you, please remember this. You have to biopsy the lump and you have to biopsy the lymph node as well. So please remember that that is the latest thing which we follow. Some more updates. If there are features of atypical ductal hyperplasia, ADH is atypical ductal hyperplasia, and these features are involving 2 or more ducts or lesions measuring more than 2 millimeters in diameter, then we term it as DCIS, ductal carcinoma in situ. Okay. Papilloma is composed of a central fibrovascular core and papillary projections of epithelium and myoepithelial cells, and it is of 3 types. You can have a solitary papilloma where the relative risk of cancer is 1.5 to 2%. Papillomatosis, where there are 5 or more papillomas with peripheral or bilateral distribution, the relative risk of cancer is 3. And juvenile papillomatosis, which is Swiss cheese disease seen in young ladies, here also multiple papillomas are there. Now, papilloma, you know, is the most common cause of bloody nipple discharge from a single duct. So, bloody nipple discharge from a single duct, it is a ductal papilloma, and we carry out a microdocectomy for these patients. Now, mastalgia, the update in the latest edition of Bailey. The latest edition of Bailey, the chapters on breasts have been written by AIMS people. So a lot of questions can come in the INICET exam from this chapter. So for breast pain, exclude cancer, reassure the patient, ask the patient to wear a tight breast support or a sports bra. Flax seeds and oil of evening primrose, these are rich sources of omega-3 and these are useful for fibrocystic disease. Fibrocystic disease, in which you know there is cyclical pain. Pain is more before the periods and then it settles down. Topical application of NSAID creams can be used. Tamoxifen, I've already told you, if the patient does not respond to vitamin E or primrose oil, then we can give tamoxifen, but this is 10 mg as opposed to 20 mg which is used in breast cancer. Danazol can be used 500 to 300 mg daily for 3 to 6 months, but you have to tell the patients that they will have altered menstrual periods. That is a major problem with danazol. Ormeloxifene is very important. Ormeloxifene goes by the name of Centcroman, and 30 mg twice a day helps in pain and also nodularity. So a lot of these patients with fibrocystic disease, they feel nodules, and that nodularity can be reduced using Centcroman. Another update regarding these cysts or nodules is the Cardiff-Lucknow nodularity score. So the Cardiff-Lucknow nodularity score ranges from 0 to 4, again seen in patients with fibrocystic disease. 0 is no nodularity, 1 is mild nodularity, 2 is significant nodularity, more in the upper outer quadrant, 3 is scattered all over the breast, and 4 is just diffuse nodularity which is there. Again, for nodularity, I've told you Centcroman or tamoxifen is useful. Another update in the latest edition of Bailey is regarding breast cysts. So breast cysts can be of 3 types. You can have smooth wall cyst. This is known as a simple cyst. A simple cyst will be a smooth cyst with no solid component. This is usually reported as BIRADS 2 and nothing is required. If it is very big, you just aspirate it. Otherwise, we don't need to do anything. Presence of a solid component. Okay, if there is a solid component in a cyst, we call it as a complex cyst. And we need to do a core biopsy of the solid component to rule out cancer. Complicated cyst is a cyst which has floating debris. So it has debris which keep on moving. And this is mainly an infected cyst, and this patient requires antibiotics. If they don't respond to antibiotics, we are going to aspirate this cyst. Another update in the latest edition of Bailey is IgM, idiopathic granulomatous mastitis. So if a patient is developing recurrent abscesses or sinuses, then in these patients, we need to rule out tuberculosis, we need to rule out IgM, idiopathic granulomatous mastitis, and we need to rule out cancer. So in these patients, we send a biopsy, we send a gene expert or CBNAT for TB, we send AFP staining, fungal staining of fungal culture is also done, right? So you need to understand that idiopathic granulomatous mastitis, patient is going to come with recurrent abscess or sinus formation, and this is a diagnosis of exclusion. You need to rule out cancer, you need to rule out TB, and then we make the diagnosis of IgM. For IgM, we use steroids in these patients, and it works very well. So the histopathology would be that of granulomas, just like TB, but AFB will be negative, gene expert will be negative, fungal staining would be negative. Only then will I put the patient on steroids. So this is another update from the 28th edition of Paley. All of the following releases neurosecretory granules except, so adrenocortical tumor does not release neurosecretory granules. A lady comes to the OPD with palpitations, heat intolerance and weight loss. On examination, there is a diffuse thyroid enlargement and exophthalmos noted. Which of the following investigations would you order? So, palpitations, heat intolerance, weight loss, all this goes in features of hyperthyroidism with eye signs, that is exophthalmos. So this looks like a patient with Graves' disease. What all will we do? First thing which we do is always thyroid function test. We will do ultrasound neck, we will do thyroid scan, and we will do thyroid antibodies. FNAC we usually avoid in a patient who is hyperthyroid till we have done the other investigations, because sometimes FNAC in an untreated patient can trigger a thyroid storm. So 1, 2, 4, 5 will be the correct answer here. You know, this is the normal thyroid scan where you see the butterfly shaped gland, both the lobes are equally taking up the contrast. Thyroid scans, you can get a cold nodule. Cold nodule is a non-functioning nodule and the risk of cancer can be as high as 20%. Hot nodule is a hyper-functioning nodule. This is a solitary toxic nodule and the risk of cancer in a solitary toxic nodule is 4%. Graves' disease shows diffuse enlargement. Toxic nodular goiter is known as plumber's disease, where you will have multiple hot and cold nodules which are there. And in thyroiditis, there is diffuse decrease uptake which is seen. Thyroid FNAC, you have the Thy1 to Thy5 classification. This you should know. Thy1 and Thy1C are non-diagnostic and non-diagnostic cystic respectively. And if you have a non-diagnostic FNAC, we should repeat the FNAC and it should preferably be an ultrasound guided FNAC. Thy2 is non-neoplastic. These patients are kept on follow-up. Thy3 is follicular. Now we know that FNAC cannot differentiate follicular carcinoma from follicular adenoma, right? FNAC cannot differentiate an adenoma from carcinoma, which is why for Thy3 we carry out a hemithyroidectomy. Thy4 is suspicious for malignancy. Thy5 is malignant. Both of them require surgery. Which of the following is not used to diagnose breast cancer? So ultrasound, clinical examination and biopsy all are utilized. PET-CT is for staging. It is not for diagnosis. You should know this. PET-CT, the isotope used is 18 FDG, which has a half-life of 109 minutes. A very common slide which is asked in the INICET exam, a 19-year-old girl with a 6-month history of swelling which moves with deglutition and shows trap muscle invasion. This you can classically see the often aniide nuclei. This is papillary thyroid cancer. The age group is also of that. Papillary thyroid cancer is the most common thyroid cancer. The most common gene mutated is BRAF. GDNF can also be mutated. If you have RET PTC3 mutation, these tumors are more aggressive as compared to RET PTC1 tumors. The histological features which can be picked up on FNAC and you can see them on biopsy also are often aniide nuclei, intranuclear inclusions and samoma bodies. So these are the classical often aniide cells. Samoma bodies are foci of dystrophic calcification and these can be seen in other tumors also like serous cystadenocarcinoma of the ovaries, papillary renal cell cancers and meningiomas. Another question regarding hyperthyroidism. You have a 32-year-old female with Graves' disease, with eye signs and enlarged thyroid. She's planned for total thyroidectomy. What can be given in the preoperative period to reduce intraoperative bleeding in these patients? This is a simple one. It is Lugol's iodine. Now, any patient who is hyperthyroid, we know we have to adequately prepare this patient prior to surgery. Otherwise, these patients can land up with thyroid storm, right? So how do we prepare these patients? So at least 6 weeks prior to surgery, we start them on either propylthiouracil or carbimazole. So antithyroid medications, PTU, carbimazole has to be started. Plus we start them on propanolol, which is a beta blocker, right? 10 days prior to surgery, 10 days prior to surgery, we can give them Lugol's iodine or potassium iodide drops, and these basically help in reducing the vascularity, and they shrink the gland and they make the surgery easy for us. Propanolol, that is beta blockers, should be continued for at least 7 days after surgery as well, to take care of the circulating hormone which is there in the bloodstream. Which of the following is seen in urine in carcinoid tumors? We know in carcinoid tumors, serotonin metabolites, that is 5-hydroxyindole acetic acid, are seen in the urine. The distribution of carcinoid tumors, according to the latest edition of Bailey, the most common site is appendix. There is no confusion in this. Men's syndrome is also a very important topic which is frequently asked in the exam. Which of the following are associated with MEN2A syndrome? So MEN2A syndrome, you should know MEN1 and MEN2. MEN1 is menin gene on chromosome 11. This is also known as Wermer's syndrome, and there are 3 P's which are seen here. You have pituitary adenomas. Which are most common in men. One is a prolactinoma. Parathyroid abnormalities, adenoma more common than hyperplasia, and parathyroid problems are the most common problems in men 1. More than 95% patients with men 1 will have parathyroid abnormalities. Pancreatic endocrine tumors, most common in men 1 is a gastrinoma. You can also get thymic tumors, collagenomas, and adrenal cortical tumors. MEN2 syndrome is because of RET proto-oncogene mutation on chromosome 10. This can be MTC only, which is a mutation on exon 618. MEN2A is Sippel syndrome, in which medullary thyroid cancer is the most common. You can get parathyroid adenoma, pheochromocytoma, and megacolon. This is on exon 634. MEN2B is known as Gorlin syndrome. You can avoid this because this can create confusion with basal cell carcinoma, nevoid syndrome as well. So MEN2B, remember it as MEN3, and there are 5 M's. You have medullary thyroid cancer, marfanoid features, mucosal neuromas, megacolon, and medulated corneal nerve fibers. Again, MTC is the most common, and MTC seen in MEN2B is the most aggressive as well. Now, the reason of knowing these exons is that because MEN2B has the most aggressive mutation, so supposing a father has MEN2B syndrome and the child is born, so the child will be tested at birth. If the child has the faulty gene and has an exon 918 mutation, then prophylactic thyroidectomy needs to be done by 1 year of age. By 1 year of age, we need to do the prophylactic thyroidectomy. Whereas if it is exon 618 or 634 mutation, the prophylactic thyroidectomy can be done up till 5 years of age because they are low to medium risk as opposed to MEN2B mutations. Now, certain updates in the latest edition of Bailey regarding thyroid. So in Thyroid, they've mentioned that 2% laryngeal nerves on the right side can be non-recurrent. This is non-recurrent laryngeal nerve. This is due to partial regression of the fourth pharyngeal arch, and this can be associated with an aberrant right subclavian artery. Left-sided non-recurrent laryngeal nerve is associated with situs inversus and right-sided aortic arch. Bayer's triangle is a method to localize the recurrent laryngeal nerve, and this is formed by the recurrent laryngeal nerve, inferior thyroid artery, and the carotid artery. Another thing which is there is TIRADS. Like we have BIRADS, similarly we have TIRADS, Thyroid Imaging Reporting and Data Systems. This has been asked many times in the super specialty exam, not in INICET till now, and I doubt that this is going to be asked, but you should know it ranges from TR1 to TR5. TR1 is benign, TR2 is non-suspicious, TR3 is mildly suspicious, TR4 is moderately suspicious, and TR5 is highly suspicious. So TR3, 4 and 5 will require an FNAC if certain criteria are met. You don't need to know the criteria for each one, but you should know that TR3 to TR5 will require a FNAC. TR1 and 2 don't require FNAC. Another update, you know about retrosternal goiters. Retrosternal goiters, goiters which start in the neck and they go into the mediastinum or retrosternal region, or they can be primary mediastinal goiters which are arising in the mediastinum, right? So there can be two types. We know the most common type is the one which starts in the neck and then goes behind the sternum. We know that majority of these retrosternal goiters can be removed via the neck incision or transcervically. And we do a CECT to see the extent. And you also know about the Pemberton sign, in which you ask the patient to raise his or her hands and there is facial congestion. So this question has been asked multiple times, that they can be removed using a simple neck incision or transcervically. But there are certain indications when we need to carry out sternotomy in these patients. What are those indications when we need to do sternotomy? When it is a recurrent retrosternal goiter, when it is a malignant goiter, when there's extension into posterior mediastinum, diameter of the goiter exceeds the thoracic inlet. Because if this is the case, then you will not be able to get it out through the neck. And also if it is a primary mediastinal goiter. So you should remember these indications. These are the indications when we have to carry out a sternotomy in a patient with retrosternal goiter. So these were the PYQs related to endocrine surgery and the updates which I feel are very important. In the next video which I put on my YouTube channel, I'll cover the updates in trauma. Thank you.